Good evening. My name is George Vredenberg, and I am the chairman of the Davos Alzheimer's Collaborative. Got to tell you that this is my favorite webinar of the year, as it brings together people committed to the cause of addressing brain disorders from around the world to better understand how we can learn the lessons of both the North and the South and integrate new tools and technologies that we discovered through the research process, validate in this cohorts program, and deliver through health systems. It's a patient-led organization. My own family has been 3 generations lost to some form of brain disorder. It is personal to me, but it is also infusing with the mission of the Davos Alzheimer's Collaborative to assure that what we develop in our work can actually be delivered to individuals around the world who are experiencing brain disorders, or where we can actually enhance brain performance and the brain capital that we bring to the economic development of societies around the world. I apologize if you hear background noise. I am in the United States Capitol here in Washington, D.C., currently the entertainment capital of the world, to bring to Congress the message of the Davos Alzheimer's Collaborative and to persuade them that they should not abandon efforts around the world as we move from one administration to the next. That while we can be more efficient and effective and impactful, we cannot forget the mission, which is to cure the diseases of the world and to prevent them from developing in the first place. So I apologize if there's any background noise that may inhibit this. I just want to make one point, which is the DAC mission. The DAC mission has been to link the efforts of high resource settings and high resource countries and low resource settings and low resource countries to assure that the advances that we can discover can be applied globally. That in fact, as we validate a lower cost and more accessible tools and technologies, digital-based technologies, that we can in fact, the advances that we are seeing in lifestyle and therapeutic interventions to the world in a way that works in low resource and high resource settings, whether those low resource settings be in high resource countries or in low resource countries. So this particular webinar is intended to bring us together to discuss the advances that are being made around the world, low and high resource countries, to assure that the solutions we develop with new tools and technologies can be delivered globally. It gives me great pleasure as we think through these issues to assure that we need physicians and both specialists and primary care physicians and community health workers around the world to actually deliver whatever prevention technology, prevention intervention that we can bring to the world. And so today is a special day because we are announcing a partnership and collaboration with the International Neuropsychological Society, and you'll hear from them in a few minutes. But I want to welcome you to this webinar, welcome you to this mission of delivering solutions to people around the world using whatever knowledge we can gain from each other from and how best to do that in whatever setting we find ourselves, and quite frankly, in whatever brain disorder we find ourselves as we detect and diagnose more effectively globally. So thank you for joining us. And I now turn the program back to our host. Thank you.
Thank you so much, George, for your work that you're doing in Washington and also for the introductory remarks here. As you announced, we have 2 very special guests on the call today for a brief announcement. So on the one hand, we have Natalia Ojeda del Pozo, who is the president of the International Neuropsychological Society, and Melissa Lamar, who is the Global Engagement Committee chair. They will introduce what I-INS is and does, how we come together on our important mission, and then we will move on to talking about and hearing from our different panelists about their cohorts and the work that that they put together for us today. So Natalia, you want to go ahead?
Sure. Thank you very much. I'm very excited about this possibility. I'm very thankful as INS president of this collaboration with the Davos Alzheimer's Collaborative. I think as you will be listening today, this is part of our mission, and we are very committed to develop new collaborations worldwide. Today, I will just introduce a little bit of what INS is for those of you that might not be so attached or so well related to the society. But the International Neuropsychological Society is one of the oldest in the world, founded back in 1967 in terms of understanding brain behavior relationships. So it has representatives in all 5 continents, up to 4,700 members throughout the world. Not only neuropsychologists, although mainly, but also neurologists, other MDs, speech therapists, and it's a multidisciplinary society, which made us really proud because this provide us with different insights in the way we address science and the understanding of brain and health in general. Our mission includes the development of science throughout the world. We are an international society, right? So we are and more so in the last years, we've been putting a focus on different regions of the world where science, and in this case, neuropsychology, but in general, brain behavioral relationships are less well developed. And you will listen today to some examples of how we address this point. In general, the society has a mission also of publishing and providing scientific information from professionals and experts through different ways. One example is the Journal of the Society, which is called DAC-INS, the Journal of the International Neuropsychological Society, that publishes several numbers per year, and also a newsletter 4 times a year at which you can find all the news and updates about what's going on, new collaborations like this one, and many other ongoing goals. We celebrate 2 really big annual conferences. Just came back from our North America meeting in New Orleans, US, and a second conference every year in the month of July, which is always hosted in any other location in the world. Coming next will be this one in Australia. You are all very welcome to join and be part of it if you are looking to new possibilities of networking and collaboration with our science. We also try to lead worldwide alliance because we understand that in our world we are facing challenges that we all have in common, and these alliances are usually better ways to address some of those. Recently, we have created a global neuropsychological alliance with many other societies in the world, like the society, one of the main societies in Latin America, SLAN, the ASBI Society in Australia and New Zealand, and also the one in the European Federation of Neuropsychology. But we are also looking forward to include here new societies from different continents, as the one in Africa, Asia, and also the one in India. The organization, the society itself, has a complex structure, many activities going on. Of course, you are very welcome to check online at our website to find about any details that you might be interested. But let me just point out that part of this structure has 13 different committees, the ones that are based in science, education, justice, equity, diversity, and inclusion, for example, is another example, and all the ones listed on my slide. Including what we call SIGs. This is to mention special interest groups. There are 12 of those. And just to give you an example of a SIG, we have one specific one related to cultural backgrounds and another one just specific based on dementia. And of course, we have the Global Engagement Committee that Melissa is going to address, because we have the opportunity to listen to her as a chair of the committee. So this is passing the word to Melissa now.
Thank you so much, Natalia, and thank you all for inviting us here, and we're excited for this collaboration with DAC. My name again is Melissa Lamar. I'm the Global Engagement Committee Chair, and together with the Deputy Chair, Lee Sharif Brown, who's in Cape Town, South Africa, we kind of represent at least 30 of our committee members. You can see where we're all located across the globe in the green highlighted countries. We have over 30 members, and we have a very large representation across 24 different countries. Our mission, so on the next slide, you'll see our mission, which is very much aligned with the INS mission. So if we could advance the slides, thank you. And that is to support the development of neuropsychology throughout the world, with a particular focus on regions of the world where neuropsychology is less well developed, including low income and middle income countries. On the next slide, you'll see some of the initiatives that we do to actually support work around the globe. One of our main kind of often called the jewel of the crown within the Global Engagement Committee is the Charles Matthews International Neuropsychological Development Fund. It was named after INS President Charles or Chuck Matthews, and it funds different programs, both related to education and training, so facilitates the holding of workshops and seminars especially into low and middle income countries. There's programs for research and clinical work as well that support and provide seed money for the development of culturally sensitive and translational measures that can be used more harmoniously and globally. I think there's a lot of overlap with a lot of the initiatives we have with Davos. Another thing that we do within the Global Engagement Committee is our research and editing consultant program, where individuals who are seeking assistance either with research methods and development for a project, or for things like using English as a second language for journal publication. We provide support to anyone free of charge for those types of services. We also have a book and journal repository where we will take in gifts from universities or others who have extra books and educational materials, and then we distribute them to versioning programs across the globe that may need those hard copy important educational materials. And lastly, one thing I want to highlight is on our webpage, we have international resources that help guide individuals not only to regional networks, but to more global networks and collaborations that they can then use to foster their own work. So that is the Global Engagement Committee within the larger INS. And just want to show you our website. So if you want to learn more, you can see some of the Charles Matthews Fund outcomes that we have and some of our awardees that have just come in this past year. So we're funding studies in India on the workshop in neuropsychological rehabilitation. And both within our research and clinical programs, we're supporting work that will translate and culturally adapt important measures, not just for dementia, but for kind of larger populations and global screenings. So I want to thank you for your time and certainly look forward to, here's just some photos of our Matthews Fund, but want to look forward to hearing about the work that's being done with Davos today. Thank you so much.
Wonderful. Thank you both, Melissa and Natalia. We're really excited for this collaboration, and thank you for sharing more background on INS today. And with that, I would move on to the introduction of our panelists today. To give a quick overview, we'll have Dr. Ana Sosa from 1066, representing the Latin American Caribbean region. We will have Dr. Edna Boisiri from Kenya, Claudia Bumps from Chile, Alfredis Hernandez from Colombia, and then Karen Blackmon also talking about the work she's doing in Kenya. And so we will hear about 10 minutes from each of these cohort PIs. We would start with Dr. Ana Sosa, please, if you could share your slides and present.
Thank you. Good morning. Thank you so much to the organizers of this event for giving me the opportunity to be with you this morning. I will to talk on behalf of the 1066 Dementia Research Group. Our group was founded in 1998. It's a network of academic and clinicians from low and middle income countries without experience in research at that time. We were led for Dr. Martin Prince from King's College London, and we are affiliated to ADI. Why this name? Because when our group was founded, it was estimated that 2/3 of the people with dementia was living in low and middle income countries, and only 10% of dementia research was carried out in these countries. What are the objectives of our group? To do good quality research, generate the knowledge around our areas, support for policy reforms, and paving the way for service development. We have, through this time, several studies that I will present briefly to you. The first study was a pilot study that we start to design in 1999, and we run it in 2 years after. This pilot study was done for validate our cognitive algorithm. And this was done, in 26 centers from different regions, as you can see. And we work with 120 subjects per each region with different characteristics, these 4 groups that you can see here, to see the capacity of this algorithm to differentiate in these groups. And then these are the countries, the sites that participate in this pilot study. And here is the publication that we did related to this validation study. And when we found that the sensitivity of our algorithms was 94%, and as you can see, the specificity for high and low education level was pretty close and very high. Then after these pilot studies, we start with a prevalence study. Previously, we developed a protocol for all the sites that will participate with all the PIs together, and then we published this protocol. At the time, our study was done with a census house by house for collecting the population that we have to include in the study. And we need to assess to the participant and to have an interview with the relative or caregiver. For this second phase of our studies, 15 sites participate in 11 countries. As you can see, 7 of these countries were in Latin America and the Caribbean and other regions. Here is the population study. Here are all the characteristics of the countries and the number of participants for each country. We have around 1,200 variables per subject. As part, we have put here some examples of them. We use instruments for evaluate to the participant and to the informant. The evaluation lasts around 2 hours and 30 minutes. Then this is the main publication of our prevalence phase. And then we compare the DSM-4 algorithm with a 1066 dementia algorithm. And then we found that algorithm was much more sensitive for detecting dementia cases. And then after that, we went to the incidence study, and we did a sub-study that the name was in-depth, that I will tell you about them. In this incident phase, we collect 13,000 participants from these sites, Cuba, Dominican Republic, Venezuela, Mexico, Peru, and China. And the outcomes were dementia, stroke, dependence, and mortality. And we analyzed some risk factors for dementia. In this study, we got 34,000 person-years of follow-up. This is one of the biggest studies of dementia incident, and mainly in our region. Here you can see the population that we follow in this new wave. And this is the dementia incidence mortality and mortality that we publish after this new wave. And here we show as an example the dementia incidence in our sites. And as you can see, even when we use the same methodology, the results are in some way heterogeneous. Then we have to take in account this. Then we analyzed the impact of dementia, and we found that dementia was the leading chronic disease contribution to disability and dependency. And we analyzed other topics as co-resident psychology strain and economic cost. The in-depth study that we did with a subsample with China, Mexico, Peru, and Nigeria had key questions related to dependence, impoverishment, and vulnerability. For this, we use mixed methods, quantitative and qualitative, and here is the principal publication that we did with in-depth study. Some findings that we got with this in-depth study was that some data that tells you that the economic impact of caring older people reduce the expenditure and food consumption in chronic households. And there is a trend to increase economic strain in all care household groups. However, regardless of the needs of care, households with older residents often benefit from income from extra resources that could be from the state or from relatives or from friends, but the health expenditure is also high. But income from external sources and healthcare spending are much lower when these households exit of this condition of care. Catastrophic healthcare spending may be more common in incident care households. Then we go to the next and last survey that we have done, which name is Last 2 Years. This is a 10 years follow-up study, which objective is monitor and improve life expectancy, focusing on fragility among older adults in middle-income countries. And we have several financial support, as you can see here. And here I'm showing you this flow chart where you can see all the waves that we have done so far. The pilot study, after that the first wave, second wave, and third wave, and then where we are so far. What have we achieved with all these years of work. There are around 150 papers with the 1066 Dementia Research Group data. We are very proud because everyone is using our numbers. We got infrastructure in 1066 Dementia Research Group for doing epidemiological studies. As I mentioned, we have no experience in research, and 4 PIs of these centers, we did a PhD in King's College London, paid for this study. An explicit knowledge has been that the most dementia burden is in low and middle income countries. We have generated arguments for the need of dementia prioritization of a public health priority, and have emerged new lines of research and new collaborations in our region. I want to make some considerations. One is that the epidemiological-based population study in Latin America have increased in the last year, fortunately. The 1066 have shown that the collaborative study can be done successfully in our region. There is a heterogeneity in the results, as I have mentioned, but it's important to consider that this variability occurs among regions, among countries, but even within the same country. The interpretation of this variability must be done carefully. I want to thank you to Dr. Martin Priest for his guidance and work for the 1066 group all these years, and here are our founders. And of course, I want to acknowledge to Davos Collaborative for the support that he has given us for create and harmonize our new data. We think that with efforts like this, partnership with 1066 and DAC is bringing together a good solution for insights and creative interventions. Thank you.
Thank you so much, Dr. Sosa. If you could remove just the slide, and then I would like to ask you a quick question. So first of all, the 1066 data, as just mentioned, we came together to harmonize, curate, and clean, so the data set is available on the ADDI Alzheimer's Disease Data Initiative platform. It is publicly available or searchable, and you can request to work with that data. And then in terms of questions and insights that you have from the 1066 data set that we could expand to other cohort partners that are speaking on the panel today. All the speakers today are actually DAC cohort partners. What do you think are insights that you have derived from your broad geography? You see this heterogeneity. How do you think that, what can we learn from your insights, and what should we be looking out for?
I think that we, in Latin America, we have a lot of similitudes, but at the same time, a lot of differences, because as you know, we have different ancestral origins, different dialects, and we have different colonizations, and the economical level in our region has a big difference among us. Not all the countries are in the same economical or educational situation, but we have in common several cultural characteristics and the language. The most of us speak Spanish, only Brazil they speak Portuguese. But I think that we, in any way, one of the advantages is that we feel like a family. Then this is an advantage for working together. But at the same time, we don't lose this point that we have some differences, and this can have some socioeconomical determinants and genetics too, because we have different backgrounds.
Thank you so much. Vaibhav, you had a question?
Oh, actually, thank you, Irene. Thank you, Dr. Sosa. I don't as much have a question, but just a quick comment. I did, on behalf of the Davos Alzheimer's Collaborative, want to thank the 1066 group for their partnership. I know we were hard together in cleaning and curating some of the longitudinal data that you have. I should also say that we are happy to state that we would be funding a DAC Global Scholar within the 1066 program with the explicit goal of further validating new diagnostic algorithms that utilizing the 1066 data. And I know, just talking to some of your PIs that you've found some interesting findings in your latest work where the incidence of dementia is in fact going up in some of the countries that you're working in, potentially with a gender gap as well. And I think we'd be interested to look into some of the risk factors and the causes for this kind of a trend. And so thank you for your partnership.
Thanks to you.
Thank you so much. Thank you for the comment, Vaibhav. Should we move on to Edna? If you want to present your abstract, that would be fantastic. And then I'll follow up with a question after that. Thank you.
Can you see my slides?
Yes, not in full screen, but we can see it. Yep.
Not in
no.
full screen.
Yes, now it's good.
Okay, thank you so much, everybody. And thank you. It's a pleasure really to talk about some of the work we are implementing in Kenya. And today I'll just be talking about a small part of the work we've done in Kenya around biospecimen sample collection for the dementia diagnosis in our region. So we all know that early screening and diagnosis for dementia is key for timely management and care. And when you talk about early screening and diagnosis, then the issue of biospecimen collection comes in. So banks plays a key role in the advancement of scientific knowledge and are the basis for discovery of biomarkers. So the biomarkers themselves, they help us better understand disease mechanisms and development of new diagnostic pathways and effectiveness of the interventions that scientists are working on. But in Africa and Kenya specifically, representation in the global biobanking revolution remains limited. We don't have infrastructure, we don't have workforce, and many other challenges, both systemic challenges that impact biobanking for dementia research. So in Kenya, there is insufficient awareness of the importance of biobanking, including biospecimen and its potential benefits for patients, the healthcare system, and society in general. So what we did here in Kenya was to explore the knowledge, perceptions, and attitudes around biosample collections for dementia, as well as brain health for dementia research in Kenya. We also needed to understand the potential factors that might influence willingness or unwillingness to donate biospecimen for dementia research, just to see what are people's take, whether they will be able to give out the different biospecimen or not. So we conducted a qualitative study in Nairobi, which entailed focus group discussions. We had 8 focus group discussions with different age groups, from young people to elderly populations in informal settlements in Nairobi. And we asked them questions around whether they've been involved in health research, including whether they've been involved in dementia research before, and their understanding of biobanking, biospecimen, as well as perceptions of various biosamples that we ran them through. Then we also asked them questions around whether they are willing or unwilling to donate different biospecimen for research. So we analyzed this qualitative data thematically using software such as NVivo. So in terms of research, we find that most people have not been involved in dementia research. When we ask the participants, they talk about other sort of research, such as a consumer product related research. And in terms of health, research such as HIV and waterborne diseases are some of the areas that they've seen researchers working in their communities. But when you talk about dementia, they actually haven't seen people conducting dementia research in their communities. And therefore, even they don't have knowledge about biospecimen collection for research. In terms of knowledge about biobanking and biospecimen, so participants did not understand what biobanking is. They also lacked knowledge on various biospecimen samples, such as saliva, brain donation, and hair for dementia research. However, participants expressed a desire to participate in dementia research and contribute to greater good by sharing their experiences and knowledge. So we had those who were like, they wanted to learn more about what we were doing and what we were talking about, and they were open to saying that I would actually accept to participate given the opportunity to participate in dementia research. We provided them different scenarios of biospecimen. For example, we asked them questions around blood and stool. And when it comes to blood and stool, participants were more open to, they understood blood and stool because of the familiarity of giving these samples for other medical tests in the country. And they didn't have a problem to provide such biospecimen samples for dementia research. The only issues that they raised were, for example, if someone has health-related issues, for if they were sick, and they also needed to know the volume of such or the quantity that might be needed. So those are some of the concerns, but they were more open to, willing to provide such kind of samples. So that is just an example. I can go to give my blood sample and then I don't know the level of blood and the amount needed to be removed. So after knowing that is when I can decide to remove, they mean to donate or to give that sample. We asked them questions about saliva and tears, and participants did not even have knowledge that saliva could be used or even tears could be a biospecimen for dementia research. They were willing to provide saliva because they said it's easier. The procedure, it's just, like spitting. So they found it easier compared to things like tear, where participants were shocked to learn it's a biospecimen, but also they said, how do you even get tear? So the thinking process around the procedure of getting tears was found to be a reason why some participants were hesitant to say that they will be willing to provide tears as a sample. When we asked them about hair samples, all participants across the focus group discussions were reluctant to provide hair and even tear because of sociocultural beliefs. So hair in our context is something that is seen. There's a lot of beliefs around hair as a sample, and even getting someone's hair. They think it's going to be used for witchcraft and other sort of sorcery and other practices that the community does not conform to. So most of them will say, hair, no, I can't give out my hair. So this is because of the social-cultural beliefs, again, as I mentioned. We asked them about the cerebrospinal fluid, the procedure. We explained what the procedure is, and because they did not understand what that was all about. But there was significant fear and reluctance amongst participants to kind of engage in this biospecimen sample collection. And the fears were around pain and potential long-term health effects. They were also wondering, do we even have a qualified provider to get this kind of sample from us? And what will happen if the procedure goes wrong? So these are some of the things that participants were more reluctant to say, I wouldn't want to participate in such an activity to collect sample around my spinal cord. When we asked them about brain donation, again, these evoked mixed reactions. Some were like, I'm happy to donate because of science, but how do I donate brain, even if I'm dead? So there were issues around consenting because they felt like when I die, it's not my individual decision that matters. Whatever I tell you when I'm alive, it might be revoked by my family when I die. So in our context, again, when someone dies, it becomes a family or community responsibility to take care of that, the deceased body. So what they were saying is, if we have to donate brain, that means you have to involve our family, you have to involve my community. So it ceased to be a personal responsibility, but a communal affair. So issues to do with how do you even bury a body without the brain because of cultural issues again. So there were hesitancy to donate brain. So overall, in terms of willingness to donate, there were factors that we were able to pick from our analysis that will be factors that will enhance willingness to donate these different samples. For example, the general health of the donor. So participants were able to tell us if the donor is healthy, then they can donate. Then familiar samples, as I said, like blood, urine, or even stool, these are familiar samples and people are more open to donating, as well as their knowledge of medical related research. We can see people have engaged in different research, but but they don't know anything much about dementia research. So those who have some little knowledge, then they are more open to such kind of research activities. And also the issue of collaboration and engagement and partnerships between researchers and public is something that they said could, help enhance donating different biospecimen. And also the issues of transparency, researchers becoming transparent and talking about the biospecimen and the procedures involved, as well as the perceived benefits for participation. So they were wondering, what are we benefiting once we participate? When we think about the factors that, that made people say that they will not be able to donate, were things to do with cultural and religious beliefs, but also limited knowledge on biospecimen, as I said, perceived pain or procedures, and non-involvement of their families. For example, if you don't involve them in brain donation, then they will not be able to give out the sample, and perceived misuse of samples. So some of them were not, were not convinced that researchers will make use of the sample properly. And there were also the issues of researcher trustworthiness and confidentiality. So these are some of the things that made people feel hesitant to contribute or donate samples. So from this study that we conducted, some of the takeaways is a need to educate the public about the importance of biosample collection for dementia research, because overall we need to collect data, we need to collect these samples to be able to even talk about the risk factors in our geographies. There's need to sensitize and engage communities on different biospecimen for research. Really, communities need to understand why we are doing what we are doing and the reason why we are collecting different biospecimen. Also, a need to address community concerns around cultural beliefs, fears, and risks is another thing that has to be addressed, as well as collecting samples that are culturally acceptable. Some of the samples that really might involve minimal invasion in terms of their collecting or the procedures involved. There's need to address key issues, ethical concerns around biobanking. As you've seen some of the people talking about trustworthiness of the researchers, the procedures involved, whether they are involved, and so on and so forth. So really addressing these ethical issues is quite important. And there's need for more research on biobanking and biospecimen. If we really need to be able to collect different samples for dementia research, we need to continue learning and understanding what the communities want, how they want us to engage them, and so that we can be able to ensure that we are able to collect samples for scientific studies. So this research, again, just to thank the Davos Alzheimer's Collaborative for funding the formative work that we've done in Kenya, including many other pieces of work that we are currently doing in the country. Thank you so much.
Great presentation. Thank you so much, Edna. How can a living lab approach that you started, how can that be useful in dementia biospecimen collection, and how have you changed your strategy to collect samples based on your initial insights for the work that we're doing collaboratively?
Thank you so much, Irene. So at the Brain and Mind Institute, we are implementing the Living Lab approach, which is a living, breathing, collaborative hub, which involves researchers working with the communities to be able to co-create solutions or co-create interventions. So through the Living Lab, because we are working now collaboratively with the communities, we have a chance to explain to them why it's important to collect this biospecimen, and also co-creating some of the best practice to optimize sample collections. So we have other follow-up projects where we are now collecting these samples, and we've learned from the formative work the importance of engaging the communities, ensuring that we have active participation with these community members or stakeholders, because then they are giving us feedback on in terms of this type of biospecimen we can collect, what we cannot collect, and why. And it's an iterative procedure or process, because we keep on educating them why these samples are important. Another important thing is that we are now working with other stakeholders, not just the participants, but people, local opinion leaders, and gatekeepers in these communities to be our ambassadors, to be able to educate us on how do we ensure that we are able to adapt our tools, adapt our screening, adapt our measures to fit the cultural settings where we are collecting this data. And we are working in the real context. So our living lab approach takes us to work in the real world where the communities live. So what as we are continuing with other studies, we are trying to see how do we set up even some of the collection sites to be within these communities so that community can have trust on how we are collecting the data, how we are collecting the biospecimen using some of the local existing infrastructures, working with the local clinicians, using some of the, setting up tents within the community. So there's that co-creating, working with the community, working closely with them. And also in the process, we keep on addressing ethical issues that arise in relation to biospecimen collection. So these have been very helpful, and we are still working on other studies that involves biospecimen collection. Thank you.
Thank you, Edna. I can think of at least 4 more questions I'd like to ask, but I'll hand over to Vaibhav, who has certainly.
Thanks. I'll be quick. And I just wanted to, I guess, highlight the importance of the work that Edna is doing. As we were putting together at the Davos Alzheimer's Collaborative, our Global Cohorts program, we wanted to make sure that we were going beyond just, getting informed consents mechanically and getting into communities and collecting data. We wanted it truly to be a community-led approach, this living lab approach that Edna is talking about, to really understand the local cultural facilitators and barriers to collecting data, collecting biosamples. And I think this is going to be hugely important if we have to scale these programs and get engagement from our participants for long periods of time. And one thing I would say is that the clinical anthropology work that Edna has done is something that we are looking to do in our other cohorts as well, wherever we collect data and biosamples. And so really, I think this is a very important component to doing cohort studies, data collection studies, and doing research in different parts of the world. So thank you, Edna.
Thank you so much. Let's move on to hear from Chile. So Claudia.
Hello. Just checking my audio. Do you hear me well?
Yes, we can hear you and see your slides.
Thank you. Thank you. Good morning, good afternoon, everyone. On behalf of the Maule cohort, which we call MAUCO project, I am delighted to present to you some results and the scope of this cohort that we have in Chile. We have already working with MAUCO for the last 11, almost moving to the 12 years. And over time, we have been conducting research and nesting studies in MAUCO and join international collaborations. So we are very happy now that we have been part of the Davos collaborative group. And as you can see here, it took us around the first 4 years in collecting the baseline information and samples. And recently, we already reached our sample goal of 9,000 participants. MAUCO in numbers, as you can see briefly here, is that we have more than 9,000 participants, over 48 years of old. All of them had a baseline visit plus 1 or 2 follow-up visits over time. We have been conducting surveillance of events, and good news for any longitudinal study that we have most of our participants still willing to participate and to be active in the cohort. We have already 500 participants who have died, and slow attrition, as I already said. We did the mini mental test and some cognitive questions for all participants at baseline and for subgroups at follow-up, as I will show you later. The cohort profile with all the details about the establishment and the procedures of the cohort has been already published. So here you have one of the methodological papers that we have been published. Now, I'm going to spend the rest of the time of this presentation sharing with you some of the results that we have been exploring and analyzing on trying to identify sociodemographic and clinical factors associated with cognitive decline and progression of subjective memory complaints. And as a brief introduction, we know that dementia is one of the most difficult current public health challenges. And this is important in Chile, as in many countries, we are facing an epidemiological challenge. However, most of the evidence on dementia risk factors, progression, and management comes from high-income countries in Europe or in the US. So understanding of the factors associated with cognitive decline in Latin American populations seems to be crucial for public health planning and service development. So we conducted a retrospective cohort study aiming at analyze sociodemographic and clinical factors associated with progression and understanding these factors. In terms of the methods, I would like to say that MAUCO is a prospective population-based cohort designed to study the natural history of cancer and chronic conditions in Molina, a semi-rural city located in central south region in Chile, approximately 200 kilometers from Santiago, the capital. MAUCO participants were recruited, as I already showed you, between 2014 and 2020, using a household census sampling. In this analysis, we included participants of the MAUCO cohort aged 38 to 74 years old, without subjective memory complaints or with a normal mini-mental test score at baseline, and evaluated the incidence of subjective cognitive complaints or cognitive decline at follow-up. Subjective memory complaints have been defined as a self-experienced worsening of cognitive capacities, independent of performance on cognitive tests. They have been suggested that as a preclinical phase of dementia disease. However, between 5 and 84% of older adults have subjective cognitive symptoms, and we haven't explored how many people with subjective memory complaints develop dementia in our country. No, people with subjective memory complaints were defined as those who answered yes to any of the following questions. Does your memory fail frequently? Or do you notice being slow to think, plan, or solve problems? Or do you have problems paying attention? So simple questions, as you can see for this population. Then we conducted this analysis trying to identify the sociodemographic and clinical factors associated with progression of subjective cognitive complaints and cognitive decline in adult population from the MAUCO cohort. Well, talking a little bit about our results, we identified near 1,500 participants without subjective cognitive complaints and a little bit over 1,700 participants without cognitive impairment at baseline. The mean follow-up was almost 5 years. The average age at baseline was near 55 years old. 35% of the population were 60 years or older, 74% female. And an important thing, perhaps for the discussion, almost 31% had less than 6 years of formal education. Well, in terms of the results, we found that 17% and almost 12% developed subjective cognitive complaints and cognitive decline at follow-up, respectively. Now, showing you some of our analysis in this figure 1, we measure and estimated the cumulative probability for the incidence of subjective memory complaints or cognitive decline in the sample. And as you can see in the last graph of figure 1, at your right, people with subjective memory complaints at baseline had a higher cumulative probability of developing cognitive decline, which was expected according to the literature. And now, in these figures, you can see the hazard ratios from the multivariate Cox proportional hazard models for the risk of subjective cognitive complaints at the left and cognitive decline at your right. So you can see that the use of antidepressants and the use of benzodiazepines and depressive symptoms were associated with a higher incidence of subjective memory complaints. And on the right, a higher number of medications, a lower Mini-Mental score at baseline, and subjective cognitive complaints also at baseline were associated to a higher risk of cognitive decline during the follow-up. In summary, our study highlights that factors associated with subjective cognitive complaints and objective cognitive decline may differ. The development of subjective cognitive complaints was associated to mental health symptoms and could serve as a predictor for future cognitive decline. But overall, these findings underscores the importance of early detection and targeted interventions for at-risk populations. To our knowledge, this is the first study that explores factors associated with the incidence of subjective and objective cognitive symptoms in Chile. One of the main strengths of this study is the use of a large population-based cohort and validated instruments to measure our outcomes and covariables. Some of the limitations is the lack of follow-up in all MAUCO cohort participants and an important proportion of missing values in the Mini-Mental test score. Nevertheless, missing data for cognitive tests in research context is common. And we were able to address this problem with multiple imputation and other techniques suggested in the literature. And the sensitivity analysis comparing results with and without Mini-Mental, missing values, did not differ significantly, which support the statistical approach that we have taken. It is also important to note that the MAUCO cohort does not necessarily represent all the Chilean population. And as you may see, Chile is a very long and thin country, and our population, the central Chile, may differ importantly from the northern and southern population. Well, finally, I would like to acknowledge all the MAUCO collaborators and the funding entities, including at the Pontificia Universidad Católica de Chile and the Advanced Center for Chronic Diseases, and of course, the Davos Alzheimer Collaborative Group. Thank you very much for your attention.
Thank you, Claudia, for your presentation and these interesting insights. A more general question, what's the difficulty? And you mentioned the geographic spread, but what's the difficulty of building up and sustaining such a comprehensive, big cohort as you have it? And then you have very minimal attrition rates, only 280 decliners out of 9,000. How do you do that?
Well, thank you, Irene, for the question. Well, I think as my colleague Anna already said, that maybe Latinos, we are a very special population with attachments to your city and to your towns and to your community. And one of the things that we decided to do when we first started this cohort was to use a community participation approach. So we had our community involved since the very beginning of the MAUCO project. And in this town, Molina, almost every adult belongs to the cohort. It's very similar to the Framingham cohort study in the States. And so MAUCO has become a social actor in the community, and in a zone where lack of resources and problems with your health system is a thing of the common daily life of people. Having the possibility to have the universities and academic actors involved in trying to understand diseases and preventing of diseases and promoting health in your community has been very valued over time. But as you point, the follow-up is another thing. We already have the cohort. We have been followed our participants for almost 12 years, and our participants are still very happy and grateful because they are learning along with us, from their own diseases, and they want a better future for their generations. So I think that we still have the people commitment with us, and this has been thanks to an important effort of our local teams. How do we do to sustain this for other 10, 20, 50 years from now? We would love to have younger populations involved, like in Framingham. We have been unable to have the resources to do that. So I will be happy to share with my colleagues here and with the Davos group, maybe common strategies and how to create and find solutions, because science is expensive, and for countries like Chile, the investment in science is still very small. So every 5 to 10 years, we have to see if we can continue with this cohort. So that's for now, and thank you for your question.
Thank you so much. Vaibhav, if you have another question.
Yeah, just got reminded as Claudia, you were talking, we at Davos are looking to collect some more longitudinal data on a subset of your cohorts. And one of the things that we are bringing into these programs is more technology-enabled digital assessments that are more scalable, perhaps more suitable for engaging younger populations, et cetera, going forward. And I think it'll be great in the discussion part to see how we could think about making these studies more friendly to younger populations and also less burdensome in terms of assessments, et cetera. So look forward to that. And Claudia, please check your email.
Okay.
Thank you so much. And with that, we will move on to Colombia. Alfredis, if you could share your slides.
Good morning, everyone. Can you see my slides? Okay. Okay, my name is Alfredo Gonzalez. I am from Colombia. I live in the south of Colombia. I am a professor at the public university. And we work with other institutions, Cooperativa University and Hospital Universitario in Neiva, and with University of Strickland in Glasgow. This study is the principal research is Alfredo González Hernández and Yasmin Bonilla Santos, and my interdisciplinary team is the different professionals, neuropsychology, neurophysiology, psychiatrists, and neurologists, and other professions. The Southern Colombia Dementia Core, this core consists of 2,262 participants over 50 years old. The main characteristics of this cohort include low education levels, low socioeconomic status, exposure to different neurotoxin, high prevalence of traumatic brain injury, comorbidities, limited access to healthcare service, limited access to the educational system, and malnutrition. This region has been marked by over 60 years of armed conflict, resulting in forced displacement, urban violence, domestic violence, and high levels of chronic stress. These communities are underrepresented communities, and this population poses significant challenges for traditional neuropsychological tools, because these normative data for these tests typically come from high-income countries. Even when these data are available from Colombia, they are usually based on samples from the main capitals and urban areas. Additionally, Colombia healthcare system doesn't include biomarkers for early detection, and access to PET scanner is limited in many cities. For example, in my city, it's not possible to have this technology for help to diagnosis in the people. Screening tests are crucial because doctor in Colombia, in general in Colombia, only the doctor has no more than 20 minutes per patient. For this reason, it's important the screening test. Because, for example, the neuropsychology only has maybe 1 hour or 2 hours for measure the different cognitive process in the patients. Respect the methods in this research for global cognition screening. We use the Addenbrook's cognitive examination revise and mini-mental state examination. Cognitive marker, in this case, visual short-term memory binding test and free and cue selective reminding test. For classification of patient in ANCI and healthy controls, the criteria is Peterson criteria. Results with ACER, with sample 314 participants with average education of 3.7 years. The ACER showed higher sensitivity and specificity compared to mini-mental. The cut-off point for NCIs is different from those other regions or other countries, and we established bases on different age ranges. For example, under 60 years, the cut-off point is 83.5. For age 61 to 69 is 80.5. Over 60 years is 70.5 points. Respect cognitive markers with sample with 456 participants. The sensitivity for visual short-term memory binding test is 70%, and free and clear selective reminding test is 74%. It's important to identify with this instrument, it's possible to identify NCI in individuals, in participants not seeking medical attention. It's possible to identify typical amnestic profiles independent of education and socioeconomic factors. And visual short-term memory binding test showed significant deficits in this process binding information. Implication for this study is possible to use appropriate tools for early detection of Alzheimer's disease in this type of population. Recommendation is necessary to integrate sensitive screening tools like this into clinical practice in low and middle income countries. and development training programs for clinicians in underserved areas, and development other research for adapt more tools for cultural and socioeconomic contexts. The main challenges for this region is the correlation of biomarkers with cognitive states, correlation with epigenetic studies, and social and environmental variables. It's important to know for this community in general that the prevalence in this region of dementia is 23%. And in the last year, with my team published about the mild cognitive impairment, the prevalence for mild cognitive impairment is 53% in Neiva and 56% in Florencia. Florencia is known because the historical has many problems with conflict armament in Colombia, and the principal population is belong to rural areas, and the prevalence for mild cognitive impairment in this region is 56%, is higher than the other regions in Colombia, because generally the principal or main studies in Colombia is from the capitals, Bogotá, or in the north of Colombia, in Medellin. It's important to know what is the impact, the conflict armaments in this region, because the conflict armament in this region is over 60 years, produce many alteration maybe in the cognition, and it's necessary to correlation with epigenetic studies and social environmental variables. And the other situation in this region is the use the pesticides. The people use a lot of pesticides and don't use protection for your body because don't have a polarity. And for this reason, maybe this situation produce alteration in the cognition. The clinical profile for this population is dementia in frontal lobe, other alteration, for example, Parkinson, and alteration in language. For this reason, it's important to different studies with biomarkers and genetic studies for identify this alteration. Thank you for your attention.
Thank you so much, Alfredis, for this presentation and your insights. What do you think, and I know you've experimented a little bit as well up front, what do you think could be the value of digital cognitive assessments in a cohort like yours?
Digital, I think is important because maybe with digital instrument is possible to administer this instrument only in 10 or 20 minutes. And maybe it's possible to help this population, because many times this population don't have resources to seek medical health. And this population many times don't know about your cognition, because maybe the people only use instrumental activity during the life. But with this instrument, it's possible to visit these communities in the different underrepresented population in my region.
Appreciate that. Thank you so much. And I know we're pressed for time, so let's move on to Karen to hear your presentation, Karen.
Thank you.
Okay, can you see my screen okay?
Yes, we can.
Great. So we've heard about really different cultural geographic settings, and the Davos Alzheimer's Collaborative Global Cohorts program has done an amazing job to assemble culturally diverse representation from across the world. But then it introduces a challenge of, at the end, how do we harmonize? How do we think about comparing across these different settings. When it comes to things like prevalence and epidemiology, the 1066 have made incredible strides in solving that. But there's a lot of challenges when we think about multi-domain neuropsychological assessment and being able to even do domain-specific harmonization rather than cognitive screening. So in this talk, I'll be thinking about different ways that neuropsychologists have tried to solve these problems of harmonization and to think collectively as a group about how we can get creative and try to overcome some of the limitations in harmonizing. So I want to call attention to an amazing special issue that was put out in Neuropsychology a couple of years ago in 2023. And it includes so many different approaches to harmonization. And like neuropsychologists, we care a lot about details and statistical approaches to harmonizing, pre-statistical harmonizing, prospective harmonizing, and making sure that there is an equivalent degree of precision, accuracy, and measurement in different settings. And what we find is that's a really high bar. It's hard to achieve. On the other hand, in a public health setting, we have groups like the Oxford Center for Human Development and Poverty that have created ways of tackling measurement, international measurement, that are not as focused on measurement invariance and precision across contexts as much as they are being able to collect comparable indicators in culturally diverse settings. So they developed the Multidimensional Poverty Index in 2011, which has done pretty remarkable over the course of the past 15 years in harmonizing data on poverty across 112 different countries, even more than 1,300 subnational regions. And then we can do estimates and cross-national comparisons to determine the degree to which different countries are meeting the UN Sustainable Development Goal of eradicating poverty. So to track progress towards sustainable development goals internationally, we have to have a way of cross-nationally comparing our measurement tools. Another UN goal is, of course, good health and well-being, and that includes brain health. And that's why we're interested in neuropsychologists in coming up with ways to measure progress towards improving global brain health. Why do we care so much about that? We've learned recently from the Global Burden of Disease studies that brain health disorders, brain health conditions, are collectively ranked as the leading cause of disability. And that probably underestimates the true burden of brain health loss because of a lack of comparable measurement tools across settings. We need these type of tools to accurately track and forecast environmental exposures, as Dr. Alfredi's was mentioning, infectious disease effects, high-risk human behaviors, climate change, conflict, and all sorts of brain health stressors. So the goal is to create some type of index that can quantify and compare brain health at the level of the individual and the population to be able to characterize the intensity and the profile of brain health loss, to track changes as a function of time, events, climate shocks, interventions, or even policy changes. And then to importantly establish a degree of validity across settings that is comparable. And unfortunately, we haven't met that bar by far yet, that our measurement precision is often lowest in the settings that need that most accurate measurement. So we've heard about the 1066, which has made great strides in harmonizing data across countries. Now the US Health and Retirement Study has a harmonized cognitive assessment protocol, and they've been making great strides as well. But there is a concerning degree of cross-site measurement variance, and it suggests that there may be some limitations to adapting a specific set of tools like the CSID from the 1066 or the set of neuropsychological tools, which are standard tools we as neuropsychologists use, like animal fluency, list learning tests, to be able to adapt across different settings, often results in a loss of measurement precision in the regions where those tests weren't originally developed. So we can take a look at how that happens. There's two different ways of doing harmonization. One is retrospectively, and that might mean looking at pre-existing data sets to see where there is homogeneity or heterogeneity across different instruments. And it takes neuropsychologists to really go in and determine the similarity of different instruments and items within each data set. So if there are concerns, they might just be considered different items, but whenever there's common items, you can then consider pooling them across sites. So this was done retrospectively in a set of major studies. And the important thing to point out here is that there was only a little over a third of common instruments across these different cohorts. Animal naming was present in 6, and that there were still differences, though, in the instrument version, and there were adaptations required in administration procedures that differed, that in the end, some degree of data augmentation was required. 86% of even the common instruments required some degree of data augmentation to facilitate harmonization. Prospectively, HCAP and other studies is doing this by standardizing administration and scoring across cohorts in advance, adapting different tools to cultural linguistic context, doing standardized training and quality control, and then applying very rigorous psychometric validation and cross-site measurement and variance testing to determine the degree to which these tools are measuring the similar constructs in different settings. So what do these adaptations look like? Sometimes it might mean relaxing timing constraints on certain tests, relaxing stop rules, eliminating any culturally inappropriate items or replacing some inappropriate items with better ones for that area, or even augmenting or extending the instructions and allowing more practice. All these adaptations are essential to ensure fairness, yet at the same time, they can compromise harmonization. So we stretch and we pull and we try to fit, but the more we stretch and pull our test to fit, the less accuracy we get in the settings that require the most adaptation. So we found that what this looks like in certain settings when they harmonize the HCAP battery across, let's say, Mexico and the US, they found that even though there was a certain degree of confident linking items that were the same across settings, there was still some evidence of measurement differences across cohorts. So what that tends to look like, if you examine the HCAP data across different sites, US, England, India, Mexico, China, and South Africa, we see nice distributions of factor scores, especially in the US and England, but there is a downward deviation of these curves in settings that are culturally different from the settings in English-speaking countries in which these tests were developed. So again, coming back to the idea that when we stretch and pull and adapt, we often lose something, and that the measures we're using may not be appropriately adapted to the multilingual, culturally diverse settings where we're trying to capture multi-domain brain health. Even if we control for things like education or wealth, we see in England that there are higher scores on tests like animal fluency than in places like India and Malaysia, even when you equate for education and wealth. So what that tells us is that there are cultural contributions to these disparities in test scores that we have to take into account. India and Malaysia happen to be two of the most linguistically diverse regions of the world. Similar to Kenya, multilingualism is the norm, and we in Kenya have to adapt our test to allow for language switching. We say, qua ground vitu ni different, and that's a phrase that means on the ground things are different. We have to take into account that people use language in different ways. They translanguage, they language switch as a part of everyday communication, and that is reinforced in settings where languages like English may be used academically or in workplace, but yet indigenous languages may be used more at home. So this degree of language switching requires relaxation of some of the standard scoring procedures we utilize. In our study in Kenya, we found that by relaxing those procedures, we were able to get improvement and show a big difference when you scored based off of one language of test administration, which in our sample was the second language in 79% of participants. When we relax that and allow for language switching, we see an improvement in scores. So what that suggests is that we have to make this type of adaptation, but again, it may compromise harmonization. Another way we're approaching measurement of something like animal fluency in Kenya is to look at practice effects across 2 administrations, even within an individual. And what we found by comparing people who have a diagnosis of dementia to cognitively unimpaired, if we look at something like practice effects, we see that the difference on the 2nd administration between cases and controls is bigger, meaning that people with dementia benefit less from practice effects. So that's a within participant control that overcomes some of the language barriers that we face. So this is a study that used automatic speech capture from a key elements tool funded by DAC. Again, some of the limitations that we face in cross-cultural settings is that we know the brain is diverse. We have to be able to relax our constraints across settings. And because we're out of time, I'm not going to go into too much detail, but we want to propose a measurement framework that's very similar to the multidimensional poverty index that allows for capture of brain health condition or domains that we harmonize at the level of domain, but allow for flexibility at the level of indicators. So what that means is that in different settings, we can use different measures to measure the same construct of memory, as long as in that setting, we have validated or data to suggest that those measures are indeed valid, and we have patient and control data, case control data from that region. And in that way, we can assess people that meet criteria for brain health loss versus brain health. And we can apply an algorithmic approach to be able to calculate comparable metrics across sites using data from local normative reference groups and being able to absorb new digital tests as we go. So with that, I will cut this short and refer people to our future work on looking at this brain health index and further validation efforts.
Thank you, Karen, for this fantastic presentation. I will ask you the first group question. It might be the only one we have time for because of all these rich discussions we've already had. But we see across all the cohort partners that have presented today, we see a difficulty in diagnosing cognitive decline early. And we see a large contribution as well across all the regions of cerebrovascular risk factors. And so at the same time, we have strong ties with communities. We have willingness of participants to participate in research. The general questions I'd like to ask is, how will more such data from underrepresented regions contribute to better insight into the disease overall? And or more specifically, how can collaborating across our different cohort partners generate more insights into your cohort? Just a very short answer, big question, I know.
Oh, is that for me?
Yes, it's for everybody.
Okay, well, I'll defer to someone else.
Well, do you want to go first?
I just also want to maybe ask the audience if they have questions for the panelists to please submit them in the chat. And I believe, Caroline, you can send it over to us.
Okay, I can go first. Just a quick answer to your question, Irene. Thank you very much, and thank you for your presentation, Karen. I think that the most powerful thing that we can do for our countries and for our people in this current global situation that we have been facing as a human race is to join our efforts and to share our strengths and our weaknesses, our problems, are trying to find solutions as a global network. So doing isolated efforts, I think that is not anymore a good strategy for any country. And for us in Latin America, and specifically in Chile, that we have unique information about our people living in their own conditions. So our natural laboratories are greatly valuable, and we can share that with other populations facing similar epidemiological and nutritional and demographical transitions. But the solutions, I think that this is the only a very best thing that we can do is to join our efforts and our capacities together to not only our problems, but also sharing the things that we do well. How, as you said, Irene, how can be possible that we, with a small budget, can have complex and comprehensive cohorts in our countries? And so I think that that's important for all.
I agree, and that connects well to what Edna just said in her presentation as well. So appreciate that. Maybe Dr. Sosa, any comments from your side?
Yes, I think that so far some efforts has been done to try to harmonize the cognitive evaluations. But I think that we have to think in very particular situations, because unfortunately, we still have a population in our regions that don't know, that have not learned to read, to write, that they are complete analphabets. Then this is a kind of group that has been to see with a different space. And maybe we can harmonize if we compare, taking in account the scholarity. They should have the same scholarity, and maybe we that have people that is analphabet, we should work together to try to do some kind of evaluations that could be done to this kind of a particular population.
I agree, and I think Vaibhav has probably a comment just about that.
No, actually, I'm trying to think whether I should make my comment or somehow go ahead and address multiple questions that are showing up in the chat. But maybe quickly, I will say thank you, Karen, for sharing that example of language switching. I can tell you that I find it very constraining to stick to one language when responding, and I believe that that's a more natural setting. And I know our folks from INS are here. I think that what you're hearing is that as we do these assessments around the globe in different languages and cultures, there is at some level of fundamental tension between getting something which is very locally adapted versus giving a similar test across the board that will ease harmonization, as Karen said, right? And I think that what we have to do is to strike the right balance and really generate data that can be compared across these regions. And this was I was going to say in my closing comments, but I also think that this is very important if we have to truly evaluate interventions that are being developed, whether they are risk reduction or prevention or even therapeutics in a global setting. Like today, we really use not fit for purpose tools. And really, there is no way for us to run global studies in a meaningful way, doing comparative effectiveness of intervention. So I think this is a very important area to really drive innovation and global solution development. And unless groups like this can come together with the help of entities like INS, I think truly global solution development where you can compare the same intervention meaningfully, its impact on people's lives across different languages, cultures is going to be hard. Either we will have very fragmented studies, or we will have global studies that are really not giving very reliable data. So that's my 2 cents of further sort of motivation to work in this space. And I will now cede my closing comments time to the rest of you. And Irene, maybe you can just go through some of the questions that are in the chat itself.
I will. I'm going to answer. I'm going to answer some of them offline. But one I wanted to bring to you: how can we bring the global cohorts together and their data to match up with potential solutions?
Well, maybe I mean, I can just say that I do also want to highlight here in this webinar our partnership with ADDI, Alzheimer's Disease Data Initiative, which is a Gates venture-backed platform. And at least from a Davos Alzheimer's collaborative perspective, our goal is not just to collect data through all the partners you see on the screen around the globe, but to make that available through the ADDI platform. We will do our best to clean curate the data at source. We will do our best to harmonize where it makes sense, but to localize and customize where it makes sense. And then really it's up to the global research community to take advantage of these data sets. So we do welcome, for those in the larger audience, anybody who wants to collaborate with any of the groups you see on the screen, or who have ideas about how to cross-connect data from different cohorts. I think we welcome that, but we are, as DAC, quite committed to making these data findable and visible to the larger research community through the ADDI platform.
Thank you, Vaibhav. And I know we're over time already, which is why we unfortunately have to cut this discussion. We will continue talking to our cohorts, both individually and also together. I think there's a lot more discussion to have had about this topic, today's topic. With that, I'd like to hand over to Drew, and thank you all for your participation, for your presentations, and also to the audience, and handing over to Drew for the final remarks. Thank you.
Well, thank you very much. First of all, I just want to thank everyone for the thoughtful contributions today. It's been a really great discussion. At DAC, we're really lucky to collaborate with such incredible global leaders like the ones you heard today. We're really grateful for this partnership. And INS, thank you for your leadership on these issues and your willingness to partner with us. Finally, a big thanks to everybody who joined today. Your interest inspires us. Your work inspires us. So I'm Drew Holzapfel. I'm the Chief Operating Officer here at the Davos Alzheimer's Collaborative. And just quickly in closing, I wanted to echo a key point that was made a couple times today, and it's the importance of having harmonized diagnostic and assessment tools. That's central to what we do. It's central to what you heard today. I can't think of anything more important. This is key for conducting global studies, including efficacy trials and real-world evidence research, which will ultimately help us achieve our mission of ending Alzheimer's disease on a global scale. The cohort program that was described today in a variety of ways was started by an idea from our board member, Elias Zerhouni. Dr. Zerhouni, you may recognize as the former head of the U.S. Institutes of Health. And the goal of this program is to contribute research on diverse populations that enable the development of new treatments and biomarkers, a goal I know we all share. Today, we also heard loud and clear that the research findings are needed to influence public policy, especially when it comes to large-scale prevention efforts, and this connection is critical. And it's conversations we started in Kenya last year in our convening with Nature that will continue through the G20 this year as it moves to South Africa. Today's conversations also highlight the incredible work that's already being done. The work that's going on is so instrumental in making global equity and brain health a reality. And lastly, as we wrap up, I think we can all agree that it's important to make sure that tools and technologies are grounded in the real-world challenges of integrating them into the healthcare system right from the start. At DAC, we're not just interested in advancing research. We're equally focused on making sure these tools are integrated into clinical pathways so that they can reach the people who need them most. And so it's with this in mind, I'd like to invite you all to our next virtual session. Our next virtual session will be on May 7th from 8 to 9:30 a.m. East Coast, New York time. We'll be hosting what we call a learning laboratory. It will be virtual just like this. It will be organized by another program within DAC, the Healthcare System Preparedness Team. It will be discussing two of the newly launched programs in the U.S. that are in partnership with healthcare systems to introduce these tools for improving detection of cognitive impairment. We'll also have some highlights from the DAC cohort program from our East Africa effort. So there's a lot to look forward to. We'll get you details on how to sign up. You can always visit our website at davosalzheimerscollaborative.org and sign up, and updates will come to you. So we look forward to seeing you on May 7th. We look forward to seeing you many times this year and continuing the collaboration. So just lastly, on behalf of our board chairman who opened the call, George Brainberg, Bob and Irene, who lead this important work for the Global Cohorts program. Thank you all for your engagement, commitment to this incredibly important work. Have a good day.
Thank you, everyone.
Thank you. Goodbye.